So what actually happens when the most important door in your body gets stuck? I want you to imagine a highly pressurized room where the only exit is this heavy door. Now, picture that door starting to rust, stiffen, and eventually fuse shut, all while the pressure inside just keeps building and building. Well, that is exactly what happens inside the human heart during a condition that we're going to unpack today.
Hey everyone, and welcome to today's Explainer. Today, we're analyzing a fascinating high-stakes medical condition known as aortic stenosis. Now, this isn't just some structural flaw. It's literally a race against a hidden clock. For years, it operates completely under the radar, but once those alarm bells finally ring, the timeline for survival drops dramatically. We're going to explore the mechanics, the hidden causes, the physical clues doctors look for, and the incredible modern medical interventions that are saving lives right now.
Here's our roadmap for this explainer. We'll be covering 1. The heart-stuck door, 2. Causes of the calcified valve, 3. The ticking symptom clock, 4. Listening for the clues, 5. Grading the damage, and finally, 6. Fixing the broken door. Let's dive right in.
Starting with Section 1, the heart's stuck door.
Aortic stenosis is fundamentally what we call a left ventricular outflow obstruction. Think of the aortic valve as the final doorway that oxygen-rich blood just has to pass through before it's pumped to the rest of your body. When this valve becomes stenotic, which just means it thickens and stiffens up, it acts exactly like a stuck door. To compensate for this, your heart has to generate an immense amount of pressure just to force the blood through that narrowed opening. In fact, to even be clinically diagnosed with aortic stenosis, the forward velocity of the blood being pushed through that valve has to reach at least 2 meters per second. That is a violently fast jet of blood.
And this sets off a total domino effect. We call it the mechanical toll. Because the heart is working so incredibly hard to push blood through a tiny opening, the left ventricular systolic pressure absolutely skyrockets. The heart also has to squeeze for a much longer period of time, which increases the ejection time. Now, just like any muscle lifting heavy weights at the gym, the heart muscle bulks up, a process called hypertrophy. But here's the dangerous irony, right? This thicker, bulkier heart muscle requires significantly more oxygen to function, while at the exact same time, that longer squeezing time actually decreases the window when the heart gets its own blood supply. It is a perfect storm of increased demand and decreased supply.
So why does this happen in the first place? Let's move to Section 2, causes of the calcified valve.
What's really fascinating here is how powerfully a patient's age dictates the likely cause of the disease. A normal aortic valve has 3 little flaps, or leaflets, but some people are born with a congenital defect where they only have 2, a bicuspid valve. Because a bicuspid valve undergoes abnormal mechanical stress from day 1, it tends to wear out and calcify much earlier in life. So, in developed countries, if a patient shows up with aortic stenosis and they're under 70, it's almost always due to a bicuspid valve. But if the patient is over 70, it's usually acquired. It's just the natural wear and tear and degenerative calcification of a normal 3-leaflet valve over a long, active lifetime.
But geography and systemic health also play a massive role. In developing countries, for example, rheumatic heart disease is actually the most common cause, where the leaflets basically fuse together, leaving just a tiny central opening. There are also some less common culprits that can cement this valve shut, things like end-stage renal disease, which totally disrupts mineral metabolism and speeds up calcification, or autoimmune diseases like systemic lupus, erythematosus. Even rare metabolic disorders like Fabry disease or Paget's disease of the bone can be to blame.
Which brings us to Section 3, the ticking symptom clock.
Now, this disease is an absolute master of disguise. For 10 to 20 years, a patient can have this progressive obstruction and feel entirely fine, 0 symptoms. During this asymptomatic, latent period, survival rates are actually excellent. The patient's heart is just quietly compensating by bulking up its muscle, completely masking the mechanical failure happening inside. But, as you might guess, this compensation cannot last forever.
The crucial point is what happens when those compensatory mechanisms finally give out. This brings us to the SAD timeline. SAD, an acronym for syncope, angina, and dyspnea. Once these specific symptoms appear, the disease literally falls off a cliff. If a patient develops angina or chest pain, average survival without treatment is just 5 years. If they experience syncope or fainting, especially when they're exerting themselves, survival drops to 3 years. And if they develop dyspnea, meaning shortness of breath and heart failure, they have an average of just 2 years to live. Without intervention, mortality skyrockets to over 90% within just a few years of symptom onset. Make no mistake, this is a medical emergency.
So, How do we catch it before time runs out? Section 4. Listening for the clues. Think of the doctor here as a mechanical detective. If the door is stuck, you're going to feel the effects downstream. This is exactly why a classic sign is something called pulsus parvis et tardis. That's Latin for a pulse that is both weak and late. When blood is forced through a tiny, stiff hole, it creates this slow-rising, low-volume pulse in the arteries. Doctors might also feel what's called a heaving apex beat on the patient's chest. That's a direct physical manifestation of that thickened, overworked left ventricle. And because the valve is so stiff and barely moves, the heart's second sound, the actual sound of the valve closing, becomes super soft. The normal acoustic splitting of the heart sounds can even reverse, meaning the order of the valves clicking shut happens entirely backward.
But the absolute most famous clue? The murmur. When you force a high-pressure jet of fluid through a narrow opening, it creates turbulence. Through a stethoscope, this sounds like a harsh crescendo-decrescendo murmur, meaning it gets louder and then quieter during the heart's contraction. It's usually loudest right over the aortic area, and the turbulence is so intense that the sound literally radiates all the way up into the carotid arteries in the neck. Interestingly, sometimes the high-frequency sounds can radiate downwards to the apex of the heart, which tries to trick the listener into thinking it's a completely different valve issue. This is called the Galivarden phenomenon. It's almost as if the heart is actively trying to throw the doctor off the scent.
All right, Section 5. Grading the damage.
All these clinical signs build into actionable stages. Doctors have to quantify exactly how stuck the door is using precise measurements. A normal aortic valve area is about 3 to 4 square centimeters, right? But once that area shrinks below just 1 square centimeter, the disease is officially classified as severe. To maintain blood flow through an opening that small, the pressure gradient, which is the difference in pressure between the heart and the aorta, has to rise dramatically. A mean gradient of greater than 40 millimeters of mercury is severe. Doctors calculate these exact gradients using advanced math, like the Gorlin formula, which factors in cardiac output, valve area, and heart rate.
And the absolute gold standard tool to get these numbers safely without surgery? The echocardiogram. By using ultrasound waves, doctors can directly visualize the valve's anatomy, see exactly how severe the calcium buildup is, and use Doppler imaging to measure the velocity of that blood jet to definitively stage the disease. No guesswork involved. So, what happens when the echo confirms the worst? Let's look at Section 6, Fixing the Broken Door. I want to be crystal clear here, and the medical literature backs this up perfectly. Medical therapy does not significantly affect disease progression in aortic stenosis. Basically, pills cannot unstick a rusted door. Sure, you can use medications like diuretics to manage the symptoms of heart failure and relieve congestion temporarily, but true mechanical problems require mechanical solutions. If you want to save the patient's life, that valve absolutely must be replaced.
For decades, the only real option was SAVR, surgical aortic valve replacement. This is your traditional open-heart surgery. It is highly effective, and in isolated cases, the operative mortality is incredibly low, around 3.2%, and actually less than 1% in younger, healthier patients. But a lot of patients with severe aortic stenosis are elderly and just too frail to survive open-heart surgery. That is exactly where TAVR comes in. Transcatheter aortic valve replacement is a total game-changer. Without ever opening the chest, doctors can thread a new, collapsible valve through the femoral artery in the leg all the way up to the heart and expand it right over the old, broken valve. Studies have actually shown TAVR is superior to surgical replacement for high-risk and even intermediate-risk patients.
It's a great reminder that modern medicine isn't just about cool tools. It requires a highly specialized, multidisciplinary heart valve team. You've got cardiac surgeons and interventional cardiologists collaborating with imaging experts, specialized nurses, and geriatricians. They all look at the patient's exact anatomy, their other health conditions, and their overall frailty to tailor the absolute best intervention for that specific individual.
So aortic stenosis is a mechanical failure with totally devastating consequences if left unchecked. But as we've seen, our diagnostic tools and surgical innovations today offer incredible hope. However, here is the reality we are facing. This is primarily a disease of aging. As the global population over the age of 65 continues to boom, the prevalence of this condition is expected to double or maybe even triple in the coming decades. So I want to leave you with this question. As the ticking clock of aortic stenosis becomes more and more common, is our healthcare system structurally and financially prepared for the rising tide? Take that thought with you and keep learning.